Thank you very much, David, for summarizing so well the evidence on the bilateral mammary artery. I think we're going to move forward, and we'll have the discussion at the end of the session. So now we are supposed to have a lecture on radial artery. We know that Dr. Taggart is not here. Is your fellow here, David? Or?
Yes. So
yes.
I have to apologise for this because my fellow is not here and I don't understand what's happened. I hope it's not something terrible because he has not emailed me to say he's not coming, so it's a slightly bizarre situation. So I have not brought my talk on radial arteries because he was going to give it. But what the talk would say, we have just published in Annals of Thoracic Surgery in November a complete review of everything about the radial artery, about patency rates, about how to harvest it, about using it sequentially or as a single graft, and whether you're better to use it as a composite graft from the mammary or from the aorta. So unfortunately, I don't have this talk, but what I can say is this. The best way to use the radial artery, the patency rates are better if you bring it off the aorta than as a composite graft from the lemur. And the second key thing about the radial artery is that there are now two important meta-analyses showing that the patency of radial artery and saphenous vein grafts at 1 year are identical. So if you say I'm only interested in 1 year patency rates, then there is absolutely no difference between radial artery and saphenous vein. But there are now two meta-analyses with almost 1,000 patients, following these patients out to 5 years. And after 1 year, you begin to see a differential benefit of the radial artery over saphenous vein, so that by 5 years, the patency rates of radial arteries are significantly better than saphenous vein grafts. And that almost certainly reflects the constant attrition of vein grafts year by year by year. So it seems to be that if your radial artery is going to fail, it will fail within the first year. And almost certainly most of those failures are probably early. But we can only but patients have not undergone angiographic examination before 1 year. But what definitely seems to be the case is if your radial artery is patent at 1 year, then it's very likely to remain patent over the long term. And the other crucial thing that you must take into consideration if using the radial artery, the single most important predictive factor of failure of a radial artery is the degree of stenosis in the native coronary artery. There is now overwhelming evidence that if you use radial arteries to stenosis, to a coronary artery with a stenosis below 70%, then the chances of failure of that radial artery are quite high. If you only use radial arteries in native coronaries with stenosis greater than 90%, then the chances of the long-term patency of the radial are very much better than vein grafts. And we talked earlier today about the potential role of FFR in patients undergoing coronary artery bypass grafting. And I think this is where FFR has a role to play, in that if it tells you what are the true functional stenosis in your... So we know that trying to assess the anatomical stenosis or the percentage anatomical stenosis by eyeballing it is really very inaccurate way of assessing how, unless it's over 90%, then eyeballing it is good. But where I think there may definitely be a role for FFR is in a patient being sent for CABG. If you know the functional significance of the stenosis, then it will allow your strategy to be better by placing both the internal mammary arteries and the radial arteries to those vessels with the most significant stenosis. And that, I think, those were going to be the key points. So that's a summary slide of the radial artery talk.
David, thank you very much indeed for stepping into the breach.